artery disease. What do we call PAD in here? Thank you. It is an MI of the legs. It has the exact same risk factors, exact same treatment, exact same everything. All right. What is an MI? What ischemia to what?
To the heart.
To the heart. What?
Muscle.
Yes. All right. So it is some kind of clot or some kind of buildup in the
Legs.
I'm sorry. Let me start over. What is a heart attack? It is a buildup of plaque in the coronary arteries that cause a lack of blood flow to the heart muscle. All right. So that same thing is happening, but in the legs. So it is a buildup of plaque in the arteries of your leg that cause you to not get blood flow to the bottom part of your legs. Yeah? So it's the exact same thing, right? Right. So how do we know that a patient's having an MI? What's it called when they have chest pain that is cardiac related? All right. Who's angina? Watch somebody name their kid that because you said that. Oh my God, look at little angina running around. All right, so the number one symptom that people complain of with peripheral artery disease is intermittent claudication. What is claudication? Pain with walking, and it's intermittent. So guess when it happens? When you're walking, and then you sit down and it stops. Okay, it's the same thing that you do when you have angina, right? With angina, you have chest pain with exertion. You sit down and hopefully it goes away. Yes? All right. So if they're not getting blood flow to their legs, we about to have a cold, dead leg. Yes? All right. So they will have hairless, shiny, taut skin. Anytime you see that, that is characteristic exactly the symptoms of PAD. Just like if you see unilateral calf pain, you're going to know DVT. If you see hairless, shiny, taut skin. Now, why is it hairless? There's no blood flow, so the hair can't grow. Why is it shiny? There's no hair. And then why is it taut?
No.
What does taut mean? Tight, because you have a little bit of edema down there, right? Okay. You may get arterial ulcers. What do they look like? It looks like a hole punch. Yes, very. They can be painful. Yes, and since you don't get any blood flow down there, there's not oxygen. There's not white blood cells, so they can rot your leg away if you're not paying attention. Okay. Have you ever seen a patient with PAD? Their toenails. It is very thick and very rigid because usually your nails will slough off layers, right? That's what our body constantly does. Every 7 years we get a whole new body. Y'all know that? Oh, yeah, you got a whole new body. Damn, yeah. So because your skin cells slough off so much that every 7 years, the skin that you have now is nowhere near where you had 7 years ago. That's already gone. Okay? So, but since we can't slough off those like normal, their toenails become very thick and very rigid. Okay? We may see paresthesias. What are paresthesias? Why would they have tingling and numbness in their legs? Why? Yeah, that. Weak or absent pulses, because this is arterial, right? Okay, if it's artery disease, then everything below the level of basically the femoral artery is starting to die. Yeah? So their pulses will be really weak or they may even be absent. Their leg may feel cold. Yeah? What is reactive hyperemia?
Hyperemia is blood. A lot of blood. It's an adverse effect.
How so? Wait, what do you mean?
Your body is trying to compensate for the lack of blood.
Why are you doing this? But it's reactive, so it has to be reacting to something. Okay, so here's what it is. Let's say I'm watching TV, right? And I just kicked back, and I got peripheral artery disease, okay? And I kicked back like this. What's going to happen to my legs? I already didn't have blood flow. Now, whatever blood flow I had,
It's going numb.
You can't put it down.
okay? Then when I go like this, because I already had very little blood flow, I took away whatever little blood flow I had. As soon as my legs go back down, what do you think my body's going to do? Rush blood down there, and their legs will turn bright red. That is called reactive hyperemia. Hyper means high. Emia means blood. There's a lot of blood reacting to the fact that I elevated my legs when I should not have. Are you with me? Here. All right. If I'm going too fast, will y'all tell me?
Yeah.
I mean, I'm not going to slow down, but okay. All right. Nocturnal pain. What's nocturnal pain? Nighttime pain. Why would it hurt more at nighttime? Because you're laying down. They have delayed wound healing because no oxygen and blood flow down there. Their legs are probably going to hurt because, you know, they're dying. Right? When your cells die, they scream and they hurt. Yes, yes. Pain induced by exercise and relieved by rest. That's what claudication basically means. All right. When they're exercising, right, your muscles need more blood and oxygen. They don't have it. So they're going to start to hurt. When I rest, my muscles don't need more oxygen. So it will go away. You with? Why might they have a little edema of their lower legs? Anytime you change pressure in a vessel, your body says something is wrong and it leads into the third space. That's what gives them that tight kind of skin. Okay? They have pallor of the legs. What is pallor? It's pale. Pallor means pale. So they have white legs, especially if you elevate. Because when you elevate, whatever tiny bit of blood you had in your legs is going up. Y'all with me? Okay. So with peripheral artery disease, they have a trouble getting the blood where? Down, right? We need to get blood down because the arteries go down, right? Veins go up, arteries go down. Yes? All right. So how do we diagnose? Well, we can ask them some questions, do a history, physical exam. I'm going to do an FLP. What's an FLP? Fasting lipid panel. Why am I doing that? All right. So if they have high lipids and high cholesterol, how does that play into this? That's atherosclerosis. And isn't peripheral artery disease just atherosclerosis and an MI of the legs? Yes, it is. We may do a Doppler. What am I doing a Doppler for? See if they've got pulses, right? We may do an angiography. What's angiography? Yeah, just like we did a coronary angiography. What is coronary angiography? What test is that?
Is that
What?
the cardiac?
Oh, this is the cath.
It's a cardiac cath. So we're basically doing a cardiac cath of the legs, right? We're going in there and looking at the vessels and being like, are these jacked up or not jacked up? Okay. We can do an MRA, which is kind of like an MRI, but it looks at its angiography. So use magnetic resonance imaging to look at your vessels. Okay. But the best way that we can diagnose is what we call an ABI. This is an ankle brachial index. So here's how you do it. You're going to take the systolic blood pressure from your brachial pulse. Where's that at? Up here. And then you're going to take the SPP, or the top number of the blood pressure, and your dorsalis pedis. What's the dorsalis pedis? Your foot. Okay. The patient has to be laying flat when you do that so that there's an even playing field. Otherwise, that's not fair because your arms are higher than your legs, right? If you're not sure if you can find the pulse, and you need to use a Doppler when you're doing the blood pressure so you don't mess it up. Why is your face look like that? Okay, okay. I can't tell your face quite yet. I'm almost there. Okay. So what you're going to do is you're going to take the highest pressure of the right foot over the highest pressure of either of the arms, whichever one is highest. You're going to divide that out. Okay. So let's say you did the blood pressures and you got 120 over 80, and then it was 120 over 80. So if you took the systolic blood pressure of your arms and your legs, that'd be 120 over 120. That would equal 1, right? That's normal. Yes? Okay. So 1 to 1.4 is normal. Anything less than 0.9 is considered peripheral artery disease. Anything less than 0.5 is considered severe PAD. So I'm going to put one up on the board, and you guys are going to do an ABI. Okay?
So you're not adding the arms together?
No. Right. You just pick like whichever, but out of both of the arms, which one's the highest? Okay? All right. Let's see.
I have a weird way of looking at things.
All right. So you are doing the calculation. You got the patient supine. Their right foot is 90 over 60. The left arm is 130 over 90, and the right arm is 140 over 92. So y'all try to calculate that out, and then we'll go over it together. Okay.
Is that 190 or 180? That's 140. 140.
Uh-huh. So you've got 90 over 60, 130 over 90, and 140 over 92. Oh. Oh, God, no. That looks about right.
So you're just using one of the numbers?
Which number?
Okay, I think I got it. No.
Okay, so all we're going to do is follow the instructions. That's probably about right. All right. What do the instructions tell you to do? Measure SBP from brachial and dorsalis pedis. Okay. To calculate the ABI. Yes, this is very simple. I think y'all are making it too hard. You take the highest pressure of the right foot. All right. So what's the highest pressure? 90. So 90 is your top number. Then you take, that's over the highest pressure of one of the two arms. So which is the highest one? The SBP. Right. So you take 90 divided by 140 and you get 0.64. All right. So it's 0.64. So what's wrong with this patient? Where's this patient at? But what do they have? Right. They have PAD because they're less than 0.9, but they're still greater than 0.5. Do you understand how to do it? Super easy. All right. To treat peripheral artery disease, we're going to do the same thing that we were doing for patients that are at risk for MI or that have coronary artery disease, right? So the first thing we're going to do is get your life right, right? So you want to make sure that they control their blood pressure, their hemoglobin A1C, that they get their cholesterol under control and their lipids. Since this is the whole cardiac module, I want to make sure that y'all know your labs. So if you are not very good at labs, you're going to need to get out a red flag sheet or some other sheet to make sure y'all know these because I'm only saying them one time and then I'm expecting you to know them. You with me?
Yeah.
All right. Okay. When we're looking at a cardiac patient, let's say you have a patient that has, I don't care what's wrong with them. They got something wrong with their heart. What labs would you want to run in this patient?
BNP.
Yeah.
A what?
BNP.
BNP. All right. What does a BNP tell me?
If the top part, this does indicator for heart failure.
All right. Because it tells me what?
How much of the heart's dying?
How much?
It's not dying. That's troponin.
With fluid,
Yo, what is a BNP?
Basic
It's a brain natriuretic peptide, but what does it tell me?
if there's something with fluid,
Y'all said it's for heart failure. What's heart failure?
there's lack of pump.
lack of oxygen to
But it's stretching really big. It just can't
Oh,
pump.
it's the stretching
So
of the
BNP tells me
muscle. Stretching of the
how
muscle.
much the heart muscle is stretching. So this is an indicator of CHF. A BNP greater than what is CHF?
100.
100. Okay, equals CHF. All right. If it's a heart patient, what else do you want to run?
CK.
Like your cardiac enzymes, maybe?
This-
You mean CK and B?
Yes.
All right. So our heart enzymes, like for an MI, all right, the heart enzymes we would run, like, let me give you an example. You would run troponin. CK and B are the two ones that are specific just to the heart. What do these, if these were high, what would they tell me?
Breakdown of
That
the
they
muscle.
had a
What is it telling me?
Breakdown of the muscle.
death of the muscle.
Death of the muscles. An enzyme that comes out when the heart muscle is dying. Yes? All right. If you have a heart patient, what else do you want to run?
HGH.
Huh?
Would you
Hemoglobin. Mercury.
I mean, if you're going to do surgery, maybe, but.
would you run electrolytes on them or no?
Yes, you could run electrolytes. I'm assuming y'all know your electrolytes. Yes. Okay.
Yes.
All right. But what are the other things that, think about the risk factors for heart disease. So you would need to know those labs. You would need those labs.
lipids?
Yes, like a fasting lipid panel. Okay. A fasting lipid panel has total cholesterol, right? Trigs,
LDL.
LDL.
HDL.
And
There you go.
HDL.
Am I missing one?
VLDL.
No, that's right. That's fine. This is fine. This is fine. And this is, remember, this is the rule of 50s. Do you remember that? So you want their total cholesterol to be less than 200. Their triglycerides to be less than 150. Their LDLs to be less than 100. And their HDLs to be greater than 50. Good. All right. Anything else you guys want to run? What are the comorbidities with heart disease? Like if someone has heart disease, they almost always have. Okay. So what's the lab I run for diabetes? Hemoglobin A1C. Okay. What do we want a hemoglobin A1C to be less than? 6.5%. What's the other comorbidity with heart disease?
Oh, obesity.
Yes, but I can't remember.
Hypertension.
Okay, BMI. So you want their BMI to be less than 25. All right. What's another comorbidity with heart disease?
Oh, hypertension.
Yes. So you want their BP to be less than
180.
120 over 80.
120. I knew what you meant. 120 over 80. Okay. So like these are all the parameters that we would run, and these are our goals for our patient. Are y'all with me?
Yes.
All right. So with that in mind, when we do lifestyle modifications for peripheral artery disease, I want their BP less than 130 over 80. I want their hemoglobin A1C less than 7-ish, right? Yeah. I mean, these are ideal labs, of course, right? I would like them to have normal cholesterol, normal lipids. Do you understand what I'm saying? Mm-hmm. If the lifestyle modifications fail, okay, then we have to go to medications, okay? Now, I do not want them to clot down there. So I would give them aspirin or clopidogrel. What are those? Antiplatelet aggregators to prevent platelets from gathering together and forming a massive clot. There is a nitro for the legs. Just like what do you do when a patient has angina? What do you give them? Nitro. What do you do when a patient has PAD? Nitro for the legs. It is called cilostazol. It is not included in UTME Pharm, just to let you know, okay? But it is very highly testable for ATI and NCLEX. So cilostazol is a nitro for the legs. It's a vasodilator for the legs, okay? And then because red blood cells also like to stick together in the legs because of gravity, right? Then there is another drug that you're going to give that makes the red blood cells slippery, and that is called pentoxifylline, okay? So to make the platelets slippery, we would give aspirin or clopidogrel. To make the red blood cells slippery, we would give pentoxifylline. To vasodilate the legs, we would give cilostazol. Yes. Y'all with me?
Aspirin's for what?
Antiplatelet aggregator.
No.
Antiplatelet aggregator.
Makes the platelets separate.
It's an anti.
I knew that, but I thought you said something about veins.
Okay. If that fails, then we go to surgery, just like we would do for a heart patient. What's the surgery we do for a heart attack patient? A cabbage, right? So down here in the legs, we could do an angioplasty. What's an angioplasty?
Where they go in there and they like redo your.
Yeah, they redo your vessels in order to get around the blockage, right? Kind of, not like completely like a cabbage, okay? But they're manipulating the vessels. You can get an atherectomy, just like you can do a coronary atherectomy, where they go in and chisel all of the junk out, okay? And then there is an abage for the legs, okay? It's a labage, all right? A leg artery bypass graft. So y'all see how it's exactly the same as an MI. Okay. When they are in the hospital, how do you want this patient's legs? Down. You want them down. Yeah, down. Oh, yeah. Okay. Yeah. Because you want the blood flow to go down. Do you want them to ambulate? Absolutely. Okay. Monitor their 6 Ps and their capillary refill, because once their leg gets cold and dead, we have to cut it off. This is the first surgery I ever sat in on as a nursing student, and it was long. They had to cut the lady's leg off because she had peripheral artery disease. And so they're like, who's the nursing students in here? And me and my friend were in there. And so we're like, and they're like, here. And they threw us the leg. And we had to carry it down the hallway to the lab. So we're both just holding it like.
Was it covered?
Yeah, it had like a little wrap thing. But they're like, so what? It was a cold dead leg. And I was like, I hate this job. I hate this job. Yes, because their legs get very edematous. And if you've ever smelled the cauterizing when someone gets a limb removed, it is... I was not meant for surgery, I can tell you that. All right. You need to monitor for ulcers every single day because they may not feel it because they have paresthesias, right? Turn and reposition Q2. You should already know that. That's a given. All right. Teaching for this patient. All right. You are wheeling them into surgery to get both their legs removed, and you're going to whisper in their ear, stop smoking. Oh my God. Stop smoking. Okay. You want them to exercise 30 to 60 minutes, 3 to 5 times a week. That will be across the board for every disease in this entire module. Y'all with me? All right. You're going to tell them to walk until it hurts. And then you're going to tell them, now sit your ass down. Okay. Diet. You want low fat, low cholesterol. How come? That's what led to this fasting lipid panel and all the atherosclerosis in their vessels. You want a low sodium diet. How come? That's right. We don't want any more edema, right? You want to encourage them to make sure they take their medications. And then we do diabetic foot care. What's included in diabetic foot care?
Dry your feet.
Dry your feet thoroughly. Well, you just confidently yelled that. I love that. No, you cannot do your own toenails, right? You can't. You have to get a podiatrist to come out and do it. So you should not be going and getting a pedicure. You can't go to you can't do any of that. Okay. What else? Wear firm-soled shoes, right? That are slip resistant. Yeah. No tight socks. They can't wear flip-flops or sandals, things that would rub. And then remember, they have to get a mirror every day and look at their feet, right? Y'all remember this? No hot or cold. So they can't soak their feet in warm water. They can't go into hot tubs. They can't put ice on their feet because they can't feel it. And they don't know when it's burning or freezing their feet off. Okay?
So they just use lukewarm water to take it back?
Yes. That sucks. That's not the worst thing that happened to them. So, but yes, I agree. It's rough. All right. Keep the BMI less than 25, which we already talked about. Flip your papers over real quick. All right. You have a patient that has been diagnosed with peripheral artery disease. You are doing the discharge teaching. You're going to tell the patient that you'd like to maintain their total cholesterol less than 200. You'd like their BMI less than 25. Their hemoglobin A1C less than 6.57 is fine too. That's fine. You're going to see a little different resource everywhere. You want their BP less than 130 over 80 because 120 over 80 is good, but at least less than 130 over 80 would be if they were 128, that's fine, right? You want their LDLs less than 100. Their HDLs greater than 50. You want their triglycerides less than 150. You want them to exercise how much? 30 to 60 minutes a day, 3 to 5 times a week. What diet do you want a patient on for peripheral artery disease? Low sodium, low cholesterol, and low fat. Damn it. Okay. All right. How do we feel about peripheral artery disease?